You can see me, you can hear me, then you are in the Should Physical Therapy Hurt session with Dr. Jonathan Fass. We are so excited to have you back tonight as part of our conference. Whenever you spoke on our Facebook Live a few months ago, it feels like forever ago at this point. I know everyone really loved hearing from you, and I know tonight's presentation will also go well. So just wanted to definitely welcome you. Thank you for being here, and I will let you take it from here.
Okay, thank you so much, and thank you for having me. So good evening, everyone, and welcome. Thank you for attending tonight's discussion. Should physical therapy hurt? I know this is a topic that, unfortunately, I think many of you have asked yourself, and so I'm hoping tonight to clear up a few questions and to give you some more insight into what that journey for you might entail. So when we look at the literature, when we ask the question, well, what should we do to help those that experience CRPS? It's very clear, almost universally, physical therapy is part of that process. It's talked about in high regards in review papers and studies, and it really is one of the fundamental parts and keys to recovery from CRPS. So for example, in this paper here, Complex Regional Pain Syndrome, a systemic review of the literature, past, present, and future management, they recommended that the available literature strongly supports the importance of adjuvant physical therapy and occupational therapy in the treatment pathway for patients with CRPS. So open and shut, there you go. This is what you do and you'll get better, right? But possibly not. See, if we dig a little deeper in the research and get into patient experience, what is it like to navigate healthcare and medicine while experiencing CRPS, we see something that is a little bit different. So from this paper here, which was a series of interviews with people that have gone through the process of trying to find answers and to begin their journey of recovery, frequently health professionals were unfamiliar with the condition, leading to delay in diagnosis and subsequent treatment. Participants described frustration that they felt they had to independently find specialist services and reported the need for personal persistence to be referred on to specialists. So what's going on here? If physical therapy is so important and medical treatment in general, why doesn't it work better? Why don't we understand more expertly what to do? Most importantly, when you do find individuals that say that they're specialists, they say that they work with condition, why is it that sometimes outcomes are less than optimal? Why does it sometimes hurt? Should it hurt? Is pain part of this process? And if you're trying to reduce your pain, does that even make sense? So tonight we're going to discuss these things, but before we do, I have a few basic concepts that I want to talk about first. Is this fact or opinion? Well, when I talk, I'm trying to speak to the literature. What does the literature say? I want to give you the best information that I have possible, but it is ultimately an argument being made. The research may say one thing, and we're going to try to use that research to give us some indication and some answers. But ultimately, what I'm making is an argument. And reasonable people, intelligent people, and trained people can come up with different answers. So I hope that you will take this for what it is, which is one interpretation, one example of how things may be produced and what you might expect from that. The question of, but it worked for me. There may be some things that I talk about that I may say, I wouldn't do this if I were you. And yet for some of you, those very things may have been the stuff that helped you. That does not take away from that. When we look at research or when we look at any experience, there's always people that will do well when they're not supposed to, and unfortunately not do well when they are supposed to. So this is not meant to detract from your journey. It's not meant to detract from anything that you're experiencing, but rather hopefully make fill in the picture, give you more information. And if some of these techniques worked that I may not employ myself, that's fantastic. The ultimate goal is that everyone should get better. And however that is done, that's okay with me. In terms of who this is applied to or the experience that I bring to the table, I am I work in the United States and I was trained in the United States. The information that I talk about, although should be generalizable, there may be some aspects, especially the first half of this presentation, that is more focused to the United States and a Western view. That is not to discount other regions, other areas, and I hope that this will be universally received, but there may be some details and differences between what happens here in the US versus somewhere else. This talk will focus primarily on the central nervous system. When I speak about CRPS, I'm talking specifically about that aspect. That does not mean that the physical qualities, the changes to the physical body are not important, nor does that mean that we should somehow ignore them. But this will talk more specifically about what we see happen in the central nervous system and how that affects pain and our understanding of it. Finally, there will be discussion regarding pain with images that could be upsetting to some. There's some artwork and pictures of minor injury and some amputation. And I put that forward only because I don't know what is or is not sensitive to you, the viewer, to you, the listener. And I want to make sure that if you know that certain images may be upsetting to you, that you know that they are a minor part of this presentation, but I want you to be prepared. I certainly did not set forth to put something that is upsetting. My assumption is that most of you will not feel that way, but I do not claim to know what is or is not upsetting to any of you. So please be aware that there will be a few pictures there. Without further ado, today's agenda, we're going to start with how did we get here? We're going to give a brief history of our understanding of pain and how physical therapy developed within that understanding. That's going to be important when we talk about what we should look for, because we need to understand what we have learned and thought and understood throughout history, and how those historical understandings may shape what we do currently, right or wrong. Then we're going to transition into what should you do as the warrior? What should you do to find good physical therapy? What does that look like? And ultimately answer the question, should that hurt? So we're going to start with our current definition of what pain actually is. And that was recently updated in July 16 of this year. It is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. That's a pretty complicated sort of definition, and certainly that is potentially new for many of you. That's not what we typically think of. We think of, well, pain hurts, but it's perhaps more complicated than that. But to understand how we've arrived at that determination, let's look back and see what that definition meant throughout history. So we're going to start in ancient culture, the ancient world, including Greek medicine. Disease and pain were thought to be caused by demons, or they were punishments from gods. And really, when we think about that, there's a lot of that still remains. I think all of us, regardless of the type of pain we may or may not be experiencing, and I don't presume to know the experience that you have, but when we have something that hurts us, very often we think of the idea of, what did I do? Meaning that we somehow did something to cause this pain. If we can't figure that out, then it becomes looking back, searching for the answers. What did I do? What caused this? Why is this happening? And that, after all, speaks to this idea that the ancient people really did believe that their pain and their health in general was an external cause. They were punishments, they were gifts, but they weren't about anything that individual was or was not doing. Now, this changed when Hippocrates came about. This is the Hippocratic Oath. He is called the father of Western medicine. And one of the things that he understood was that medical practice became a naturalistic concept. He believed that this was a balance of humors, and you may have come across this idea of blood and bile and phlegm, these natural qualities that occur in the system. Imbalance in this would then cause illness or perhaps pain. And this was the first time that this became a more naturalistic thought. So taking it from the external, from demons and gods, and placing it into the internal, something that happens within us, and therefore something that potentially we could affect. We later turned to Descartes. In the 1596 to 1650, he was one of the great geniuses of history. He was a philosopher, a mathematician, and a scientist physician. He gives us Cartesian coordinates that we may have all suffered through in math at some point in school. You may have heard cogito ergo sum, or I think, therefore I am. That was also Descartes. He has touched on so many aspects of our knowledge and understanding, both philosophically and scientifically, that many of his beliefs and ideas, especially in math, still exist today. He also gave us an understanding of pain that lasted centuries. In the Treatise of Man in 1664, he thought of the body like a machine, and pain was transmitted through the nerves to the brain, and he described them as hollow tubes. They attached the strings to bells, which would ring and alert the brain that the foot, in this situation, had experienced pain. So pain was now a direct line sensation from the body to the brain. The foot is telling the brain that it is in pain. So we have this direct line sensation. It takes into account things that are found like nerves, but it also makes the brain a passive player. The brain collects information, and then we know that something is happening. At this time, we turn to physical therapy. Physical therapy originated as a professional group. Per Henrik Ling, who's known as the father of Swedish gymnastics. He founded the Royal Central Institute of Gymnastics in 1813 for massage, manipulation, and exercise. Not so long afterwards, the term physiotherapy first appeared in its German form. So somewhere in the 1800s, we start to see things that may resemble or look like physical therapy. In 1916, physical therapy really took effect, and that was during the polio epidemic. So young women were treated, they were trained, they were nurses prior to this. They treated polio with residual paralysis by using passive movements. They were stretching them. Physical therapists developed manual muscle testing for assessing strength and muscle re-education techniques for weak muscles. And this certainly starts to sound a little bit like what we think of as physical therapy. Now, it's important now to realize that during the beginnings of physical therapy, things that even sound like what we do today, we were understanding how the body works, health, disease, and pain through what Descartes told us and explained to us. This idea of you are in pain because something tells you you are in pain. But what happens when we have an injury, such as what Descartes described, but we don't have pain? So that's something Descartes couldn't explain. If the foot is in the fire, the bell should always ring. But what happens when it doesn't ring? Now, we don't have to go too far to think of an example. I'm sure that every one of you at some point or another has seen a bruise on your body somewhere, and you went, when did I bang my limb? When did that happen? The bruise is evidence of injury. It is specific injury that occurred. It disrupted blood vessels. You see discoloration, yet you have no memory of it. You had no experience of it, and you had no pain from it. Descartes can't explain that. In other words, it's only a flesh wound, and nothing comes of it. I don't stop. I don't change. I don't do anything to adjust my behavior. It just happens, and I don't even know that it happens. In 1965, the gait control theory was proposed. This was proposed by two giants of modern pain science, Wall and Melzack. What they proposed was this idea that nerve impulses to the spinal cord are gated. That gating is influenced by these fibers, large fibers or small fibers. Small fibers will open that gate, large fibers will close that gate, and therefore they inhibit pain. They literally stop the signal of pain from reaching the brain, so the brain will not receive that information and won't know about it. But they did make one additional comment. they felt that the gait could also be influenced by descending nerve impulses from the brain. So when a critical threshold is reached, there's an action system that occurs. But if the brain says not today and closes that gate, there is no action. We don't experience it. We don't change our behavior. This is the first time that the brain is seen as having an active role in our experience. It's no longer a passive recipient. It now takes part. It can decide, I don't want to know about this, and it can close the gate. That's a profound idea, and it does explain this issue. How can we feel something but not feel it? How can we have injury but not experience pain? But there is still a problem here, and we'll discuss it. But first, what's happening in physical therapy? Well, at that time, we were entering the Vietnam War. Physical therapists were used as part of the medic team to restore the use of damaged arms and legs, rehabilitate surgical wounds, increase range of motion, and restore flexibility and strength following serious burns. It sped patient recovery and repaired the wounded soldier. Again, we're starting to see things that branch out, sound more like physical therapy, sound more like orthopedic physical therapy, in fact. In the next decade, around 1967 to 76, we saw further expansion of the profession, not just in warfare, but now in non-war circumstances in the population at large. We were managing orthopedic and cardiopulmonary disorders. Physical therapy began to be practiced in preoperative and postoperative units, and the care to individuals with severe joint restrictions altered with increasing practice of joint replacements. So this really starts to look like modern physical therapy, what physical therapists do, the patients that they treat, the types of conditions that they see. So this was all done, performed, and determined under the concept of gait theory. Not initially at first, because anytime a new idea comes about, we need to explore it, we need to study it, and we need to decide whether or not we believe it. So we're seeing really this combination between what Descartes proposed and what gait theory proposed, which is really just an addendum to what Descartes was talking about. But here's the problem. What happens when we have pain but no injury? Now, again, we all know what that experience might be. Every one of us has likely had the experience of a headache. And although there can be very significant issues, and a headache can be part of a disease process, I think most of the time, hopefully, most of us do not think that there is a serious physical problem when we have a headache that we can reach for a Tylenol and make better. So we can experience an injury without pain, but we can also apparently experience pain without injury. And the most pressing question in the medical community was phantom limb pain. So phantom limb pain was first described by Ambroise Paré. He was a 16th century French military surgeon. This was also described as a Civil War surgery in the 19th century, and it was coined phantom limb pain. Phantom limb was originally thought to be psychogenic. Psychogenic literally means it's in your head. And I hope that is not the case, but unfortunately believe it probably is, that many of you have unfortunately been told that at some point too. And it is wrong. It cannot happen that way, and we'll discuss why. But in the original times, in the 1600s, in the 1800s, that was their first guess. But later they thought maybe this isn't actually made up, but rather that it's an irritation to a nerve. And they would amputate further. They would remove those nerves to try to eliminate the phantom limb pain. But those surgeries were rarely successful. And they can't explain individuals that were born with missing limbs, but they also experience phantom sensations, which is true for a large proportion of individuals born without a limb. So we still can't explain this through Descartes, the idea of there being injury, and therefore that is the only way that we can experience pain. So we're going to wait until 1989 to come up with a proposed theory. And that was proposed by Ron Melzack. He is the same scientist that was part of the gate theory. So he, in 30 years, continued researching, learning, and discovering, and comes back and proposes this theory. Unfortunately, Patrick Wall, his partner, had passed away at that point. So Melzack is the only one attributed to this, but certainly Wall had something to do with it. In his theory of the neuromatrix, he proposed 4 conclusions. He said that the experience of phantom limb has the quality of reality because it's produced by the same brain processes that underlie the experience of the body when it's intact. He felt that neural networks in the brain generated all the qualities of experience that are felt to originate in the body. Inputs from the body may trigger or modulate or change the output of the networks, but they may not be essential for any of these qualities to be experienced. He felt that the experience of the body has a unitary and integrated quality, which includes qualities of the self, meant that the body is uniquely one's own body and not that of any other individual. Now, this is an important place to pause here, because it is a well-known experience that many warriors experiencing CRPS do not have that feeling. They don't feel that their arm belongs to them or their leg belongs to them. And many of you may have experienced that feeling too. It just feels like it's not part of you anymore. And that's why, even though this is a discussion of phantom limb specifically, there are very specific connections and ideas that combine the concept of phantom limb with CRPS. And those underpinnings and the nervous system underpinnings share many similarities between the two. The final conclusion was that this neural network that underlies the experience of the body is genetically determined, but it can be modified by sensory experience. So the neuromatrix ends up taking all of our experience, the experience of pain, and says that that is a domain of the nervous system itself. The nervous system uses all the information that comes to it, all the information and senses that we get from the body, and including our history, our beliefs, our memories, everything that we know about a situation, so that pain becomes an experience that we perceive in order to change our understanding of what is happening to us, and most importantly, an understanding of threat to the body. And that goes back to the original definition that we started with. It is about the potential of tissue damage, real, actual, or potential, because a smart system doesn't wait for something bad to go wrong. It says, I don't like the look of this. That can be because nerve information is saying there is damage to skin, damage to bone, etc. But it can also say, if this condition continues, there will be damage to bone and damage to tissue, because it makes more sense that the alarm bell rings before the house burns down rather than waiting for the house to burn down and then the fire alarm goes off. But what's the point, right? Why did I take you through this entire journey? Well, we're going to ask Thomas Kuhn for the answer here. He was a philosopher of science, another one of these great mental individuals. And he argued that scientific research, contrary to what many of us may think as this process that continues through time, learning, ever learning, is more defined by paradigms, which are worldviews, scientific worldviews. They consist of formal theories, experiments, and methods. But they tell us, hey, this is reality. Let's learn more about the reality as we describe it. But eventually what happens is theoretical problems or experimental anomalies may expose a paradigm's weakness or may contradict it altogether. And this would cause a crisis. This causes, how can these two things be true at the same time? And we have examples through history of this: Newtonian mechanics replaced by quantum physics, or general relativity. Right now, we are in a medical paradigm shift, and that's what all this is about. Our understanding of pain, of how the body functions, and most importantly, how we can help it, is under a shift and a change in understanding. We saw that. That's what we just talked about. We went from Descartes to the gate theory, and now neuromatrix and central nervous system and all these neuroscientific types of ideas. We went from the brain being a purely passive recipient of information to a brain that is active, actively generating our understanding of reality. And this has major implications. So have we been all wrong, right? Has everything that we developed under as physical therapists, and therefore how we treat as physical therapists, has that been wrong? Are we getting everything completely off? And how does that affect you? Well, not exactly. And we can go back to Newton and Einstein to understand that. Newton gave us laws that still exist today. He described physics in incredible ways. Einstein came along, though, and said, this isn't quite true. It's really close. But when we look at really small things, atoms and molecules even, we get into the realm of quantum mechanics, well, your theories break down. And we get into the realm of really big things, black holes and stars and light at really high velocities, your theories break down. But what's important to understand here is that we put satellites in orbit using nothing more than Newton's laws. So he's not wrong. He's just not quite right. And that's kind of where we are. Many of the theories that we developed over time as physical therapists, as medical practitioners, many of them are still very much legitimate, and they can work under many circumstances, but they're not always quite right. And when we look at a condition such as CRPS, that is clearly involved, it draws on multiple areas in the physical and nervous system, the physical body, the muscles, the joints, the nerves, the connective tissue, the immune system. We need better theories. Our theories will break down when we come across conditions such as CRPS. So an extremely brief, simplified explanation from Surfing Uncertainty, which is a phenomenal book, and I recommend it to everybody. It's not light reading, is brains like ours are predictive engines, constantly trying to guess at the structure and shape of the incoming sensory array. And this, although that seems a bit foreign and it doesn't seem quite right, it's actually quite accurate. What it means is that we don't see, we get information, and the brain interprets that and says, then this must be what is in front of my eyes. We don't hear, we receive nerve impulses, and the brain says, then this must be what it sounds like. We are predicting what this information means. And most importantly for us, and when we treat CRPS, is that those predictions are off. We don't know why. We don't know why this happens to some and not others. But we do understand at this point that the brain is functioning absolutely normally if the information that it received and its understanding of it were accurate. But there is an inaccuracy. And because of that, we are experiencing the symptoms of CRPS. The brain is trying to understand what is happening to your limb, your body, and it's getting it wrong. And our job is to try to help it to get it right. So let's compare that to what is currently recommended in PT practice. It's called movement system impairment. The underlying idea is that sustained alignment in a non-ideal position and repeated movements in specific directions are thought to be associated with several musculoskeletal conditions. Treatment is based on correcting impaired alignment and movement patterns, as well as correcting the tissue adaptations associated with the impaired alignment and movement patterns. Now, does that sound like what we've just described? The idea of how the nervous system operates? Not exactly. It doesn't mean that it's wrong in all circumstances at all times, and it's certainly far more progressive and advanced than ways that we would have treated previously, but this isn't quite there yet. And when we get to issues of CRPS, that's important to know, because you may interact with physical therapists that work under this understanding. Not all physical therapists do. Some aren't even doing this. But it does make sense when you may or may not have been told that something about your posture, something about your strength, something about any other number of issues of the physical body are why you're experiencing this. The physical body is important, but it doesn't give us all the answers. So that leads us to the question, what physical therapist should you see? Who knows this information? Who can help you to get better? Well, let's take a look at myself. Let's see what I do. And does anything that you could read in a bio tell you about that? I've been working with chronic conditions for nearly a decade now, CRPS more specifically in the last couple of years. Where's my training from? Well, let's take a look. So the first things that you'll see behind any physical therapist is something that says PT. That means that we passed our basic boards after graduate school, after physical therapy school. The DPT means that I have a clinical doctorate. That is the current degree granted. You may see others. MSPT is a master's, possibly even a bachelor's in physical therapy if they were around, they got their degrees in the 80s. It doesn't necessarily mean anything. It certainly doesn't mean that I have any specialty training in CRPS treatment. It just means that I am legally able to practice physical therapy. And I'm board certified in orthopedics. Board certification, you will find that in many different fields, medicine, of course. The difference here, though, is that in medicine, it is a requirement. It may not be in Florida, don't check me on that, but in every other state it is. In physical therapy, it's not. So normally in the medical model, we would go through residency training and then we would sit for specialty boards. This happens after graduation from medical school. So it's training specific to the field that you want to practice in. You go from a generalist to a specialist. In physical therapy, that's not required. And I can practice without board certification. I can also sit for my boards without having gone through residency. I did attend residency, but not everyone has to do that. So in the minimum, it means that I have worked for 2,000 hours and I have studied and taken a test in specialty practice. This is orthopedics, though. It's not anything having to do specifically with CRPS. There are a number of different specialties, but there is no specialization in the treatment of pain in physical therapy. One is currently under development. I don't know when that will come about, but as of now, there is no clinical specialization, clinical specialist. The next letter is COMT, Certified Orthopedic Manual Therapist. That is a series that I took, a series of courses, training. I had to study, I had to take a test, I had to take an in-person test. It wasn't very easy. But what it also wasn't was specialty training in CRPS. There are a number of these types of specialty certifications, and you will see many of them. But it doesn't mean that any of them have to do with what you are experiencing. These next two, they're personal training certifications, certified strength and conditioning specialist, certified exercise physiologist. This is actually when I was a personal trainer during grad school. I've maintained those certifications, but as you've guessed, it has nothing to do with CRPS. And finally, fellow in training. I've actually finished everything in fellowship. I'm waiting for recognition from the academy, but I still can't write that I'm a fellow yet. But what fellowship is a 2 to 3 year process. It is advanced learning. It is the highest level of clinical practice in this case, orthopedics, but it is not CRPS related training. About 1 to 2% of physical therapists will go through fellowship training. About 10% or so will be board certified clinical specialists in a field. So these are significant in terms of professional practice, but you're seeing the trend here. There is nothing here in my bio that speaks directly to my knowledge, experience, or ability to treat someone with CRPS. In fact, in all of these labels here, every single one of them, none of these have anything, any information that tells you this is the person that I need to see. And certainly this is not every single type of license or certification or specialty that someone can achieve, but none of them have anything to do with CRPS. So if you come across some of these certifications, there may be some value. A fellow of the American Academy, a neurologic certified specialist, because they are dealing with neurological disorders. That is not exactly CRPS either, but at least that is the nervous system and its function, as well as orthopedic specialists, but again, dealing with the musculoskeletal system and the nervous system that moves that, but not specific. I also mentioned certified hand therapists because very often they may encounter individuals with CRPS because upper extremity CRPS is the more common. So sometimes you may find a certified hand therapist that has a good amount of experience. There is also some specialization courses. These are just some of the institutes that will grant a fellowship or certification in pain management, but it is important to say that they're not accredited programs. That means that they're not overseen by the American Physical Therapy Association, and therefore what they're teaching may or may not be reflective of an agreed upon course or curriculum. But it is important to know that they're out there, and if you should encounter an individual with this type of training, that may be valuable to you. Again, not specific to CRPS, but at least in concepts of chronic pain and a more recent, mature understanding of what pain actually is. So finally, that we've come across all of this, how does this all work? How does this knowledge transfer? What does it mean clinically to you? So first thing we have to look at is general physical therapy. This is effectively what has been taught, what I probably would have learned in school many years ago. It's a combination of talking about what CRPS is, insight, advice, support, relaxation exercises, connective tissue massage, TENS units, which I'm sure many of you have had, exercises for reducing pain, skills, body position and posture training, and training skills themselves. This is the standard of practice. Unfortunately, it's not terrifically good. So according to this review for CRPS, the authors found that although there seemed to be some benefit to physical therapy when compared to occupational therapy or social work, which was used as a control in addition to medical management, there was a small difference, but that wasn't clinically important. So the difference was there, but it doesn't mean anything to your day-to-day practice. Therefore, general physical therapy, your everyday average, I'm going to go to physical therapy and whoever the front desk gives me is who I take, we're not going to accept that. That is not going to end up being what you need. Pain exposure therapy. This is going to start to answer the original question that we posed. Should this hurt? So pain exposure therapy instructs that patients are directly exposed to pain. Patients are instructed to ignore the pain because it's not real, quote unquote. They'll ignore both the verbal and nonverbal expressions of pain during the treatment, the practitioners will, and all medication aimed at CRPS, including analgesics, is stopped, and use of crutches or other aids, splints, bandages is discouraged. Now, when we think back to how this would have been developed, this doesn't quite sound like neuromatrix, like a brain trying to understand itself. This is, for lack of a better term, fairly violent. It is aggressive. It's assuming that because there's no real damage, and understand that I say that facetiously, that is a false statement, then the idea is just to expose you to it until you just get used to it. Fortunately, as of now, this doesn't seem to do a good job. And I'm grateful for that because, and this is my personal opinion, but I do not believe in this. And I think that is nothing but cruelty. So the research shows that between group difference was not significant between standard practice and a pain exposure therapy. And the authors could not conclude that pain exposure therapy is superior to conventional treatment. And we just saw that conventional treatment isn't very good. So if you have experienced that, there will be some people that make it through to the other end. There will be some people that improved. Again, there is no blanket statement. There is no one treatment for everyone. Physical therapists or anybody that engages in this style of treatment is not necessarily a bad person. They are almost certainly very well-meaning, very well-intentioned practitioners that to their understanding, this is the way that it works. But in my opinion, we probably don't want to go down that route. And because the research does not support it yet, and because of the outcomes that the cost associated in physical terms to you to undergo that, no, pain should not occur. And we have a partial answer to our question, our initial question, but we'll come back to that. So what does that actually mean? What do we do? If standard practice doesn't work, then what should we do? Well, the best available data shows that graded motor imagery and mirror therapy may provide clinically meaningful improvements in pain and function in people with CRPS. Many of you, I hope, have already heard of this, and I also hope that some of you have, in fact, undergone this treatment. It is a gentle and simple approach. It is not meant to produce pain. In fact, it's meant to alleviate it. So graded motor imagery is a 3-stage process. In the first stage, you look at flashcards. There is also an application, and you're asked to identify either a left or right limb. We're trying to help the nervous system understand the body, and we do that by looking at other bodies. In the second stage, we may imagine movement. There's some debate to that stage, but that is the second stage of it. And in the third stage, we use a mirror box. Now, mirror therapy involves concealing the affective limb behind a mirror, and the non-affective limb is positioned so that its reflection is superimposed. It basically looks like you're looking at the other side. The brain has been shown to prioritize this input over the input that it's receiving from the limb itself. So when you move your unaffective limb and it looks as if you're moving the affected side, things start to function more normally. Aerobic exercise. Now, aerobic exercise is a cornerstone of treatment in chronic pain conditions as a general statement. It has been examined in CRPS, but in CRPS patients following a stroke. So that means that it may or may not actually be applicable to you, but it's worth considering. In that study, patients reported significant pain relief after adding aerobic exercise to their routine. So once we've gone through the graded motor imagery, our nervous system is functioning more effectively, aerobic exercise may be an outstanding option. Now, what about manual therapy? With a little luck, will be a fellow of the Academy of Orthopedic Manual Physical Therapy. Well, in fact, there's not really much there. It may provide some short-term relief, and that may be valuable, but there's not a ton about manual therapy and how it may ultimately affect your function. Now, if you happen to hear me speak before, I mentioned a concept called neuromodulation that I use extensively. Clinically speaking, through experience, that seems to do fantastic things. So it is one option for you. It should be known that I am authorized to teach it, although I have not because of COVID, unfortunately. But my intention is not to earn money from you, but just to let you know when I teach it, I'd actually just like other practitioners to learn it because I do feel that it is beneficial, but that is my opinion. There is no research to support that. So what about everything else? Do we just throw it away? Do we stretch? Do we desensitize? Do we exercise and build muscle? Well, very possibly so. I personally think that it does need to be part of the program, but we need to do it in an order. If you are in pain and I tell you to exercise, that is unlikely to make things better, certainly not in the short term. But if we have worked on the nervous system through graded motor imagery, through mirror box, through some additional techniques that, such as I saw someone in the comments talk about artificial, using goggles to look at computerized environments. All of that shows promise. There's not enough research to support it just yet, but that doesn't mean that you don't. The beauty of what we call evidence-based practice is not that it's simply the research, end it, stop it, we're done here. It means that I utilize that research, but I also take into account my clinical judgment and, most importantly, you as the patient, determining what is best for you, because every one of you is different and every one of you is unique. And how we go about the process must be unique to you, because it doesn't make sense if it's not. So for the answer of should physical therapy hurt? In the beginning, I will argue no, it should not hurt. That doesn't mean that you may not be experiencing pain as you begin, but the things that we do should not increase that pain. After you've gone through the process, pain has begun to reduce. There's more consistency, more predictability. I know if I do this, I will hurt, and it will hurt for this long at this intensity. Then we can make judgment calls. Do I exercise? To what parameters? How much should it hurt? How quickly should that pain return? Those are judgments, but it should be under your control. When you have the control back, those things can be decided upon, but it should not start, because if our nervous system is trying to understand the nature of its body and itself, then by hurting it, by causing conditions that the nervous system feels that it is under threat and rings the alarm bell that I need to get away from this scenario, we are only reinforcing the concept of danger and insecurity to the body, to the self, to your continued survival. We need to move in a way that we reduce that excitation of the nervous system, the physical contributions, and the nervous system itself, the contributions that occur, peripheral nerves, central nerves, all these types of things. When that is calm, then we can start to challenge. And then it becomes like anything else. Exercise in the gym hurts, but it hurts good. We get muscle soreness, and we know that that's good. We need to be at a stage where we can receive that, and we can only get there if we start with gentle, encouraging, and safety. And if we do that, good things happen. So it takes a team. I've talked about physical therapy, but I can't do what I do if not for good medical practice, pharmacological, potentially psychological services. We need everyone together on the same page. Good physical therapy is good medicine, is good psychology, is good everything. Most importantly, you need a partner. So when you walk into that interview with your physical therapist, will they be your partner? I would rather have someone that isn't so sure but will not rest until they find out, than someone that is so sure that they know what they're doing that if you don't fit, then it doesn't fit. You need someone that is adaptable, that is reasonable, and that is constantly trying to learn, because this information comes at us in lightning speed. But in truth, the clinical applications still are going to take time. We're in the middle of a paradigm shift, and we need to be smart about what we do. We need to interpret, and we need to understand. You need someone willing to do that. So in this talk, we talked about the history of pain. We talked about how physical therapy and rehabilitation came about within that history. We learned about what is more modernly thought about, how we understand the body, how we understand our experience, and how CRPS may fit into that. We've seen that physical therapy has a way to go. We don't have the means to describe good physical therapy and how good physical therapy can help you. But there are hints, and I hope those hints have helped you. Your journey is a long journey, but it doesn't have to be a frustrating one. And if you find the right support, you can become whole again. I want to thank Alexis, I want to thank Jim, and I want to thank all of you. I hope that this was helpful to you. And that is my daughter. Do we have any questions?
Hello, this was so awesome as usual.
Thank you.
I know you've been able to see the chat, and I've also been collecting questions in the chat. So we have about 10 minutes. And so be sure to leave any questions that you have in the chat so that we can ask them. But I have collected a few, like I mentioned, and the first one's from Christine. Thank you, Christine.
Okay.
She asks, or she says, one challenge with PT is that the therapist or insurance company measures our progress and uses the same goals that's used for a non-CRPS patient. How can warriors get around this?
It is a fantastic question. And unfortunately, insurance companies very often are not really built for that. There are a number of ways that you can demonstrate progress in something that is understood to not make very quick progress. And I tell my patients, whatever time frame you think it's going to be, multiply it by 10, probably double that. And that's the kind of things that we're looking at. There are specific CRPS measures that can be used. There is something, the neurological measures that can be used as well. So that therapist should be guided towards that. They can't use something like the lower extremity functional scale. It doesn't work. My company does the same thing. So I actually just print out the additional things I want to see. At the end stage, they do come into effect, but not for a very long time. Also, when we look at things like the graded motor imagery, I'm constantly taking those scores because that shows improvement. We know that it correlates to function of the nervous system. So if I show that your time is improving, your accuracy is improving, that's evidence right there. And it does actually, and I didn't mention it, but it really does mean that your therapist really needs to write great notes, because if they can't convey that information, their insurance will not approve more. So it is a battle that you have to fight, but you can do that.
Awesome. Yeah, insurance is definitely I feel like it definitely is a fight.
Yes, unfortunately, yeah.
Yes, and I just saw a question from Madison that I wanted to ask before I lost it. Is physical therapy something I should be seeking even if I have function, my limbs?
Great question. Physical therapy can help to improve that function. Really what it means is, do I feel that there is something wrong, something that could be improved upon? So if I can function with the pain, it may be the benefit to say, well, if we can reduce that pain, your function can improve. I don't think that it changes anything, but I will say that, and something I didn't mention, that although, again, I don't really recommend the pain exposure, patients that I've received after that are usually a little bit, I can touch them more, I can do different things with them. I'm not sure if the juice is worth the squeeze there, but it does end up being that they may be more functional because of that. But at the same token, those patients aren't necessarily feeling good. They aren't necessarily walking about like nothing has happened, and there is a role for good physical therapy in that. But ultimately, it's a personal choice, a personal decision.
Definitely. So we had a few questions. I saw two, one from Tara, one from Maria, and they were asking about like using ice or ice water or using heat. So I was like, going on, both ends of the spectrum.
Yeah.
Are either end of the spectrum like recommended for physical therapy?
Absolutely. So those things may be beneficial or not, and we can use them for different reasons. Typically, ice is something about inflammation, but it can be analgesic. However, nervous systems will respond to ice. We're predisposed to get greater danger from cold, because if it's cold, I can get frostbite, I can lose a limb, I can ultimately die. In the heat, I might get a bad sunburn. And while that's not a great thing, it's not the same level. So our nervous system, it's a soft sign. If we feel pain when the weather changes or when it gets cold, it's a soft sign that the nervous system is pretty involved in this. So I can use heat, I can use cold, and it depends for what purpose. If I'm trying to alleviate pain, then anything that works is good. I don't care what it is. If it works, it's good. But at the same time, there may be something about exposure to experience. Very often we see differences where something cold feels hot or vice versa, or it's extremely hot when it's just warm, these sort of things. So there can be a role for that. Again, in that second level, once we've gone through the established protocols, there may be room for things like that.
Okay. And I see there was someone else who mentioned that, she tried, ice, and it actually ended up damaging her limb because she couldn't feel what she was doing. So I
Exactly.
definitely think
Yeah, those have to be judiciously employed. It is a fact that the number one cause of lawsuits in rehabilitation is for hot packs, burns from hot packs. So those things have to be employed cautiously. If you know that it's helpful to you, then be careful about it. I do not recommend plugins because that can be on all night and that can be bothersome. But 10, 15 minutes for most people will be acceptable. But again, there is nothing here that must be done. It's a matter of what works for you. The GMI is probably very important, but beyond that, it's whatever works.
So if a warrior goes into, or visits with a new PT, and this, PT does understand CRPS, what are like the first questions after that? Like, yes, you understand CRPS. I'm so happy. What other questions should warriors ask, once they find that PT?
Absolutely. So I think that second part of the presentation is that type of thing. So what does your treatment look like? What can I expect from this? How long will this take? Those kind of basic questions, but the reason that I wanted to go into a little taste of what pain might be is because we now hopefully have a filter, right? If I know that this is sort of some guy told me that this is what's going on, and now your physical therapist is telling you things that don't quite match up, we got to be cautious about that. So questions about what are your procedures? How many patients have you worked with? What have their outcomes been? What are your expectations? How do you handle insurance? And what do I need to know as the patient? Any of those things and anything that is valuable to you. A good physical therapist will know that you're about to ask that question before you ask it. So that can also be maybe a little hint when they're answering questions that are in the back of your head and you weren't even going to ask them. So
definitely. So I hope you all heard that, because I know there were a few questions there. So I definitely want to make sure that I reiterated that. Cassie's asking, are there any PT exercises that warriors can do if they are in a wheelchair?
Oh, great question. So exercise is relative. So the answer is yes, but I think I would still begin again with the idea, have you gone through that graded motor imagery process? Assuming that you have, then a lot of times what I like to do, so if it's lower limb, I'd actually like to start in the upper body. Healthy bodies move, healthy bodies exercise. If I can do something that employs movement of any type and it's not affecting my region, my hot zone, that's going to be beneficial. So the first thing I would actually recommend is potentially doing things in areas that are not painful and do not hurt. Let's normalize the nervous system to movement, to activity, and to make that a safe thing. When activity for the upper feels good, activity for the lower may start to occur as well. Ultimately, though, I'm looking for anything that I can do that's not going to flare, or if pain increases, that is predictable decrease and predictable. It can go up this much, but not that much. And of course, the types of qualities of that pain are going to be important as well. There's not just 1 5 of 10.
Right. So we have 1 minute left, and I'll end that minute just asking one more question. Can a physical therapist help with energy levels and stamina?
Yes. So there's a process that I like to use. And again, there's so many things that could be discussed, but I like to talk about activity points. So we'll talk about what is the one thing that you do that, if you had to do this today, I'm out. I'm done for the rest of the day. I woke up, I did this one thing, and now I'm going to lie in bed the rest of the day. For many people, it could be doing laundry or 2 loads of laundry, walking for 5 minutes, whatever that might be. I'll assign that typically 10 points. And then what we're going to talk about is, so what is brushing your teeth? Or what is standing to make a sandwich? How many points do you give that relative to this 10-minute walk or whatever costs 10 points? What you start to do, and what the issue becomes for many people, is on a day that is good and low, I try to do as much as I can. And then it becomes the next day is horrible, the day after is horrible. So we want to normalize that. And it doesn't mean necessarily that I should do all 10 points every day. But if I'm having a real rough one, I'm going to still try to spend 7 or 8.
Right.
And if I'm having a great one, I'm not spending more than 10. It breaks down your day in a more quantifiable way. And sometimes it makes you realize, like, wow, I'm using up like 15 points every day. And when that happens, we start to normalize not only the experience that we have, but energy, activity, my ability to engage. And it's all about prediction in the early stages. Can I predict what tomorrow will be based on what today is? And unfortunately, many people do not have that prediction. And giving that prediction and working in order to do that changes everything in what you're able to then do from that point forward.
Good to hear. Good to hear. So thank you all for joining us. Of course, thank you, Dr. Fass. We always love having you. Your Facebook Live from a few months ago, we're still getting views and questions on that one. So yes, I know there's a lot of compliments and people really appreciating you in the chat.
Absolutely.
But
my pleasure.
Thank you so much. And once again, this entire presentation will be available on YouTube. So we will definitely be sure to send it out so that people can watch it over and over. And of course, reach out with any questions. So yes, have a good night.
You too. Thank you so much, everybody. Be safe. Be well.